Okay, there's two things regarding tubes. There's a total of 9 critical elements that you have to tell me if you got the NG tube. One is position the patient in high fallers. 2 is measuring the length of the tube and lubricating the tube. The tube is lubricated about 4 to 6 inches. Just open your lubrication, just go like this. That's good enough. How do you measure the NG tube for NG tube placement? Tip the nose to the ear, xiphoid plus maybe 2 centimeters, right? Okay. There are 2 positions that you need to remember. When you first start, the patient's going to be in a, you already told me the patient needs to be in a high fallers or semi-fallers, which is about 40, 45 degrees. Do you know how to raise the bed 40 to 45 degrees?
Yeah, there's a level here at the bottom.
Right, you just raise it up and you can kind of look on the bottom to make sure it's between 40 and 45. Patient needs to be positioned into high fallers, and then when you start, when you're going into nasopharynx, the patient needs to be hyperextended back this way. And then your other component is once it goes down into the oral pharynx, you can, on the mannequins you can look. I can see it's in the oral pharynx. I would normally take a tongue blade. If you want to take the tongue blade, you can. I'm taking the tongue blade, I'm looking, and I can see the tube in the back of the throat going down. At this point, the patient needs to flex down, take a sip of water, take a dry swallow, or suck on the straw in order for them to swallow, and that's when you advance the tube. So you have high fallers, measuring, lubricating the tube, 2 positions, 2 ways to secure. Secure temporarily on the cheek before you check for placement, and then check again, then secure again to the patient's gown. We need 2 other things. Clamp the tube. Remember I said when you first temporarily put it here, you want to clamp the tube so that no secretions come out. And then verify placement. Tell me one. Excuse me, I forgot your name.
Sandy.
Sandy. Without looking at your paper, tell me one.
Positioning the patient at the high faller or semi-faller.
Which is about 40 to 45 degrees.
45 degrees.
Another one. Think.
Clamp the tube.
Clamp the tube. Right. Joe.
Lubricate the tube.
Lubricate the tube. And kind of goes together, measuring and lubricating, right? Tape.
Tape to the side.
Okay, that's one. And what's another tape?
Gown.
Tape to the gown.
Oh, on the gown. I put it on the nose.
What else? Over here?
The 2 positions, the high pass tension.
Okay.
And
Okay.
bring down and
Flexing.
flex.
Okay, go around the room. Give me one.
Check for listening.
Check for 2 So, places. We need to go ahead and get started with this patient. So, what are we going to do first when we walk in the room?
Wash your hands.
Wash your hands. Then what are we going to do?
Check the doctor's orders.
You probably check the doctor's order before you go in the room. Okay,
Introduce yourself.
so now you come in and you're washing your hands. What are you going to do next?
Knock on the door.
Patient identifier.
Knock on the door, patient identifier. Don't be talking about what you're going to be doing because it may be the wrong patient. Don't set everything up because it may be the wrong patient. So what are you going to do? Show me what someone's going to do.
Verify the name band.
Good. Now, who wants a couple things that you need to do is you need to assess which nair you're going to go in, and you also need to assess your bowel sounds and your abdomen.
Do that before going to high powers.
Doesn't matter.
More. It's just 32.
You want to go ahead and feel the abdomen. Is the abdomen distended? Probably will. Is it maybe tender? It may be, but usually distended, maybe a little taut because it needs to be. We need to put the NG tube to decompress the stomach. So you want to listen for bowel sounds and you want to palpate the stomach. You want to. How are you going to check the nairs?
Oh, perfect. Breathing.
Tell them
Yeah,
to.
that's it.
Okay. What are we going to do next?
Explain everything to the patient.
Normally what I would do then is I would get everything set up however I'm comfortable. So I would probably go ahead and get all my supplies ready. I get my tape ready, my small one, so I don't forget to tape my cheek, the one to put on the nose, and however you wanna set up your kit.
For the test, is suction gonna be part of it?
Yes. So go ahead and put this on your patient. You're probably going to want to either explain before you put the towel on or after, but you need to explain the procedure to your patient. So talk to your patient. This is Mr. Smith.
Mr. Smith, how are you doing today? My name is John Hopper. I'm going to be placing your tube.
The surgeon ordered, you have a small bowel obstruction. The surgeon ordered placement of a nasogastric tube.
Okay, and what's your name? What is your date of birth? Alright. So now, this is part of the procedures. I'm going to have to put that,
A towel, just
towel.
just so that no secretions go on your chest.
just not to keep your pulse going.
And then you're gonna want to just explain to him, when you have a real live person, you're gonna wanna tell them what you're gonna be doing, where you're gonna be placing it. Just remember that the more you stalk over them, I think you need to put this down, okay? So you can get in here. The more you do this and do this, they're not gonna be very comfortable. I'm gonna place my hand over here, and I'm gonna have you tilt towards me a little bit. We're going to, hyperextend your head backwards, and I'm going to place this tube, I'm gonna lubricate it in a little bit of jelly so it's more comfortable. You're going to feel some irritation. The nasal mucosa is very sensitive. You may start tearing because it hits some nerves in the back of your mouth, so you may tear a little bit. You may gag a little bit, you may cough a little bit. So you wanna explain to them what the different processes that they're going to feel. We'll stop whenever you're uncomfortable, and we can start again. Okay?
And as far as
Explain the
starting and
procedure.
stopping, you're just not advancing the tube any further, but you're leaving it where it is?
When you're
It's just
doing this,
stop.
you're just gonna go through the whole process. I wanna see that you know the process of the different steps that you need to do, but
But
when you're in
real
real life practice, I would just, have my gloves on, have everything ready. Normally what I do is I would put the table on the side that I'm working, get all my supplies ready, what I'm gonna do first, what I'm gonna do second. They say in the book that you should curve this a little bit, like 4 or 6 inches, just so that it kinda goes in a little bit, so you can just wrap this around your hand when you're talking to me or talking to the patient, what we're gonna be doing. You can just wrap it around. And then when you angle it back towards the ear. So the patient, I can't, okay, no problem, all right. You just take as much time as you need. Make sure that you allowed enough time when you're placing an NG tube on the patient.
This-
Maybe you'll get an unconscious patient who's in the ICU. That's a good time to practice your placing NG tubes. After a patient's intubated, they need a chest X-ray. So you want to put your NG tube, like get the NG tube out before they come up for the X-ray, because that way you have placement on both. So, and it's really, when you're putting an NG tube in, it's a matter of grabbing your kit, washing your hands, putting your gloves on, opening it, and just going down after you do your measurements. It's that fast once you do it quick enough, especially when you work in the ICU. That's my background. You just pop it down, check placement, tape it. Okay, you're ready for the X-ray. So those are just the steps.
Would they have to keep this sterile?
No.
It's not non-sterile. It's a non-sterile, just gloves. It's a non-sterile procedure. Okay, so you're gonna open your lubricant. Normally what I do is I'll open up my NG tube with a piece of paper and explain the procedure to the patient. You need to measure. You need to measure, right? Because you didn't measure yet.
With the tip of it, right?
Tip to the nose, got the opposite way. Turn it around the other way.
Tip to the nose.
Tip to the
The
nose.
openings.
Tip to the nose.
The other side.
There you go.
Mhm.
To the xiphoid process. Let's do this again. Tip of the nose, the top of the ear, to the xiphoid process. Approximately over here, right over here. You can, and then put a piece of tape, so maybe you need 3 pieces of tape. Because you may not remember which one you're at, or that's where you're at. Okay, so next you're gonna go ahead as lubricate this. This usually comes in a little package, so I just usually put the lubricant on the package, and I just go like this. But you can go in here if you want to, that's not wrong. You wanna lubricate it about 4 to 5 inches, like about that much, so that it's easier to go down. And I was told you can lubricate these,
The mannequins.
the mannequins, that's what they told me. Okay, very good. So it's gonna be like a downward movement like this. So the patient's gonna be hyperextended because you're gonna be going into nasopharynx. So go ahead, you can breathe in. Just going on the right side.
You got it? Pressure
Yeah.
So just be relaxed, take a deep breath.
You want me to hold it?
No, it's
Is
good.
it okay?
Thank
So now you reach the pharynx, right?
Okay, so do you see it in this mannequin? You could say normally I would take a tongue blade. Do you see it in the back? So put it down some more. On him you usually can tell. Can you see it now?
Yeah, see it.
You see it?
Yeah, see it.
Okay, so then what you do after you do see it, then you instruct your patient to flex forward. Okay, sir, now we've gone through the nasopharynx, now we're gonna go to the oropharynx. And what I need you to do is take a sip of water. We're gonna flex your head towards your chest. Either swallow, they can dry swallow, suck on a straw, or they can take some water to help. And while they're doing that, then you advance the tube slowly.
He'd have to be able to hold the cup himself.
So when you're going through the testing with me, you don't need to pick up don't pick up that, just tell me, once I pass the nasopharynx and I get into the oropharynx and I realize it's there, and it's not curling in the back of the throat, I would ask the patient to take just like I did, swallow, sip on the straw, or dry suck on the straw. You don't have to show me that you need to pick up I think you know how to pick up a cup. Go ahead and
Okay,
advance.
since he took a sip.
She took a sip. While he's taking a sip, you're advancing.
Sit down.
Is that faster than you would go real world? Like, I don't really know
Can
like,
go
how
anywhere,
fast you're
anywhere.
jamming this thing
This-
in their nose.
It won't go all the way down on him.
They're
so don't-
asleep, probably. You're just.
No, a lot of times they're
Really?
awake.
Yeah.
No, I mean, if they were
Don't-
asleep, it would be.
Paul, you're done. Sometimes this in the mannequins it won't go all the way down. As long as it's not curling in the back of the throat, you're fine. So what do you do after it's in then?
I'm gonna tap it temporarily on the.
So grab
ledge.
maybe grab 3 tapes, okay? So that you don't forget.